Welcome to another episode of the Melbourne Athletic Development Podcast. Today we're very lucky to be joined by John O'Donnell. John, do you want to give us a bit of a background to who you are, what you've done, and some of the pioneering work that has sort of been part of your professional career?
That's very kind of you, John. I'm an orthopaedic surgeon. I've been working in Melbourne since about 1990. I started doing hip arthroscopy, which is the bit that leads into some of what we're talking about today, in 1992, when that was very new and very few people were doing it. In fact, there were only really two of us in the country, David Young and myself.
What made you get into hips and hip arthroscopy? What was the driver? As you said, there wasn't many people doing it. So
yeah.
Did you feel like it was time to start exploring that?
Well, I was doing a lot of arthroscopic surgery in under joints, so hips, shoulders, knees, shoulders, ankles, elbows. But hip was just very uncommon.
Why is that? Why was it uncommon considering it was done in other joints?
Partly because it was difficult. Mm-hmm. So the hip's quite deep in and it's contained. Mm-hmm. So you have to use traction to open the hip up a bit, which you don't do in other joints. Mm-hmm. And no one really knew of any good reason to want to go looking at a hip. But it's a bit like everything. As you start to explore, you find all sorts of things you hadn't ever really thought of. And that happened with hips. So we found more and more things wrong that no one ever really knew about because they didn't show up on the tests that were available back in those days. And in order to look into a hip prior to that, you had to do what's called an open arthrotomy, which is a really big, relatively big operation. And some operations you actually had to dislocate the hip, which is a really big deal, and with potential serious complications as well. So people didn't do that unless they had a good reason, and there weren't many good reasons. Whereas arthroscopy changed all of that because it's such a small thing to do with very, very low risk, and you can actually see things that you can't see that you've had to destroy if you go and do a hip dislocation. Like there's a ligament inside the hip that in order to dislocate the hip, you have to cut that ligament, destroy it.
Ligament anterior.
That's the one.
Yes.
Yeah. Whereas with arthroscopy, you can actually see problems with that ligament that no one really knew existed previously.
One of the things that, even in preparation for this, and recently we actually had a newly graduated, she's just finished her training as an orthopaedic surgeon, and we asked her about the profile of orthopaedic surgeons. And you've already identified that you were willing to be a little bit more explorative, a little bit more innovative. And Jack and I have spoken about this a few times, the concept that surgeons seem to be a little bit different to other healthcare practitioners. Not all of them, but typically more in the physician side of things as a medical practitioner, where they are willing to maybe explore and experiment and try things that are within the boundaries of reasonable, but have that sort of slightly different mentality when it comes to what they're doing compared to other practitioners that sometimes are quite conservative. One, have you noticed that? And two, if you have, why do you think that surgeons tend to have that nature?
Jack wrote to me to prepare me for some of the questions that may be coming my way before today. And that was one of them. And I found that a really interesting question, which I've been thinking about a bit since you mentioned it. And I think there's a whole variety of answers to that. Partly, it's not universally true. There's no shortage of very conservative surgeons who've learned a method years ago, which they will continue to use until they finish practice.
Yes.
And not change. And they're very happy, and they feel it works well, so why change? So there's plenty of people just like that. But there's also a group who feel a bit dissatisfied with what we do, always feel that there's room for improvement. I think there's always room for improvement. But the hard part is to know what's just catchy and fashionable and what's truly improvement. And so I think that thankfully there's been some change in how those developments take place now. And it's not just a matter of someone comes up with what seems like a good idea and away they go, thankfully. So things have to be tested. Did it used to be
like that?
Oh, yeah. When I started, we made some of our own instruments. A friend of mine is an engineer.
That's cool.
And he would...
That's truly innovative.
This is true.
You're like, I want to solve a problem. I'm going to see
Well,
if
he
I
used to
can
assist me with operations, and some day he'd say, that thing you're using, I reckon I can make something much better than that.
Yeah.
And he would. So, a week or two later, he'd arrive with this new instrument that he'd made in his workshop. And we'd sterilise them, and obviously...
You'd hope so.
Yeah. So it wasn't quite just get out of the bag. But it was perfectly acceptable back then to do that. And so I've got a bag full of old instruments that no way known would I open these days. At the time, it was considered perfectly sensible. And in fact, there was a lot of innovation because of that. Whereas now, if you want to do something like that, then you've got to do all this testing that literally costs tens of thousands of dollars for a single instrument. So no one does it because it's way too expensive.
Yeah.
Has that changed the process, you think, of seeing innovation and changes within particular surgical procedures with sensitised amount?
Yeah, it does. And obviously it's good about it too, because you just don't want people sort of whipping something up out of the back shed.
About it, yeah,
of course.
Sure.
But I'm not quite sure where the happy balance point is, where you're being protective and not doing stupid things, but also not stifling innovation. And I think we've maybe gone too far the other way now, but it's probably better to go too far and be protective than not far enough and have cowboys everywhere. So,
yeah, true.
But I think that needs to change a bit, and we come up with some better answers.
In terms of the nature, is there certain characteristics of surgeons that tends to fall in, particularly orthopaedic surgeons, that creates that sort of culture of innovation? Is it something that's encouraged, or is that, as you said, maybe is that an era thing, that maybe era closer to your age because of that maybe previous environment that was a little bit more relaxed around exploring things is different to the younger generation?
Yeah, I don't know the answer to that. I'd like to think that there's a curiosity that still exists and a desire for improvement. And we're in a field where that's more possible because it's a more, in some ways, almost more mechanical type of job that we do. Some of it is anyway.
Yep.
And so it's easier to look at that and say, well, this method could be improved. Whereas if you're a physician and you're sure you can look at better testing, better drugs, but you can't really change the drugs. That's other people do that. Yeah. So I think we have more opportunity to look for change and improvement. But there is an element of what you're talking about and the sort of desire to change and try new stuff.
Yeah, you mentioned, the physical skills associated with surgery. And I think that you're 100% right. I think that separates surgical practitioners from other practitioners. How do you see
Well, surgeons weren't considered doctors, were they, a long time ago?
No, they were almost... They almost
like barbers.
Yeah.
Better butchers, but barbers. Yeah.
How do you see that in terms of the way in which we should teach people like surgeons or people who do work with their hands or have physical, in our profession, obviously as physios, there is a large element of manual therapy, and it's very much driven by what you can feel and how much experience you develop with that. What are your sort of ideas on how you develop that and how you develop some of those skills to maximize on your those physical capabilities?
I think the way that we do it now, which is very old-fashioned, almost like an apprenticeship.
Yeah.
I think you have to have a fair bit of that because it's not something you can just do with artificial intelligence, or that's being used more and more to sort of practice skills now, but it still doesn't have the same sort of tactile part to it, or haptics they talk about. So you have to develop all of those skills, and you can only really do it in real time on real people. But you can't just go out and practice on real people by yourself.
Yeah.
So it's a mixture of partly AI, partly watching people who hopefully have those skills to impart, and then developing them in combination with someone who can teach you.
Are there big gaps that you see just from your experience on what you like in developing surgeons, and are there key areas that you think are big focus points that they should focus on more than maybe what they do? Well,
and just to add to that, I actually would be interested to know as well, you came from a background where you said you were doing surgery on multiple joints. And I'm interested to hear, do you think that actually helped with you being a bit more innovative and creative with looking at the hip, as opposed to, what
people
happens now, specialising on just the one joint? And I understand the importance of the specialisation because you want to refine your skills of surgery.
We always have this, like, to let you know, to give you some background, we always have this argument back and forth with healthcare practitioners, and we had this argument last week actually with Paul Coburn, where he was talking about, particularly in physiotherapy, but becoming more specialised.
Yes.
And Jack and I always argue that that's maybe the wrong way to be going. That if you teach people the key principles, particularly because it's not like surgery where you have to have very, very refined, maybe manual skills, you actually get better at solving problems than if you go too deep on one problem or a series of problems related to, say, one area.
I agree with you very strongly.
Yeah. So I wanted to know your thoughts. Yeah, tell us why.
Yeah.
Well, because there's talk all the time of why train people in all these different areas when they're only going to work in one bit. So why not just scrub all the rest of it, save time, save money, get more practitioners out in a hurry. So instead of training doctors, you train hip surgeons.
Yes.
So you train someone to do nothing but replace hips. I guess you'd get good at replacing hips, but you have no concept really of anything that happens around that. So when I was trained, and I know this sounds like, good old days stuff, but when I was trained, I had to do general surgery to a degree first. I worked in vascular surgery. I did some plastic surgery. So they're all areas that are very much related to what I do now, and give you a background where you have some skills to solve problems that may develop along the way. Whereas if you've never done that, you go in cold and something goes wrong, then it's pretty difficult to deal with that. But as well as that, you have a whole lot of different ways of looking at a problem. And I think you can solve problems much better if you don't just have one very fixed focus.
Yeah, we spoke about this with Paul, but it's something that, I don't know if you've ever looked at it's a popular read book, but David Epstein's book Range.
No, I haven't read that.
And he talks about, how generalists tend to solve the problems that specialists can't, sort of thing.
Yeah.
And it's because they, as you said, they can tie together key areas they might be related, but skills that they have outside of that really specific problem to be able to come up with a solution that people maybe not have thought about because they've thought about it from a slightly different angle. And there's a series of different examples that he gives in the book, but it highlights exactly what you said. When you encounter a problem that is slightly different to what you've had to deal with before, if you haven't experienced anything outside of what you currently do, you're in trouble because you don't really have the tools to necessarily navigate that problem.
Sure, and the thought processes as well. Yeah, and it's good to be able to just take a step back sometimes and take a much broader view of what you're looking at. And if you don't have that broad view, well, obviously you can't do that. And I think it's really helpful in many times.
Excuse my ignorance, but are you teaching at the moment, or have you taught in the past? Yeah.
So I teach fellows. So I teach now. I used to teach students and everybody, but now I teach people who are trained orthopaedic surgeons. And
how do you? What kind of things are you doing for them to actually try and foster this, or do you not necessarily go into that?
They're sort of a bit past it.
Okay.
So these are guys who've gone beyond all of that, and now they're looking at very subspecialist training. So they're trained general orthopaedic surgeons. The great majority of them recently finished that training. Now they're looking for what areas they're going to actually work in. And so they come and work with me for 6 months, and then maybe go off and do other things as well before they actually start in their own practice.
Yeah, like the reason I say that is, and it's not nowhere near to the same level, but we get a lot of students that come through here. And one of the things that I know frustrates the hell out of them is we start pushing them to start looking outside of that specific problem or that specific area. So they'll come asking questions, and we typically ask them more questions than they ask us.
Well, and more importantly, I think you see that pattern where they become very methodical and protocol driven in everything that they do.
Yes.
It's like, they've got this injury, we're going to do this, this and this.
Yes.
And you go, okay, well, maybe they are appropriate.
We go down
dimensions.
stream one.
And maybe they're appropriate, but why? Like, why do you think that's the most appropriate thing? And why would you not do this or this? Or how do you start? Where do you start and set the parameters? And they look at you going, this isn't in the textbook. And you go, okay, well, let's start to think this out.
Because I'm sure there'd be many examples where even they might be observing you doing surgery and you use some sort of technique or you do something, and they might ask you afterwards, why did you do that, and where did you get that from?
And
then I'm sure
that happens quite often.
And I don't know, you probably have an example for us, but that's the kind of thing that I think starts to pique the interest, as you said, of curious people and people who want to get better, to actually go, okay, maybe I don't have all of the information that I could have to be a better practitioner in whatever I'm doing.
well, because a lot of times they come and they've worked, well, the training's all in public hospitals for a start.
Yep.
And so, because that's where the great majority of training happens. And so the sort of things I do don't happen very much in most public hospitals. So a number of these people won't have seen anything much of what I do. And so they find it very eye-opening. And they say, we've never heard of these things that you're treating. So how are we supposed to know they even exist when no one's even talked about them?
Yeah.
How much has your practice even changed over the last 5 years? Or do you constantly evolve the process of how you go about doing things?
I can answer that question. I thought not much was the answer. Because you don't really notice day to day that you're changing. But not very long ago, I had a surgeon who came to visit me, and he said, and he'd been once before, about 5 years previously. And he said, I just want to come and spend a day with you and see what things have changed. Because he said, I do exactly what you taught me, but I'm sure that's not how it is anymore. So do you mind if I watch for the day and we'll talk as we go? And I said, well, you're very welcome, but I think you'll find it's a bit disappointing because nothing much has changed. Well, I was totally wrong. And I didn't realise how much I'd changed in a relatively short time, because he kept saying to me, now, see that, whatever, this sort of abnormality that we were treating, see that? He said, how do you, I remember you told me how to treat that. You do this, this and this.
Yes.
And so, we don't do that anymore. We do that, that and that. And this happened over and over again all day, so that it would appear that most of the things I treat had changed a lot in 5 years, whereas in my mind they hadn't changed at all.
And has that change come around from more formal training, or even just changes just in the approach that you take because of like the subtle changes that you make,
or
from
even technology?
It's all of those things.
Yeah, okay.
So there's new and better instrumentation getting developed all the time, which allows us to do things that we couldn't do before.
And these, like, what kind of things are you talking about?
Instruments, just methods of doing something. So that's part of it, but that's just the doing. It's why you're doing it that's changed too. And so that's changed because it's a pretty close-knit, relatively small community of surgeons who do this type of hip arthroscopy, and most of the major ones all around the world I know. A lot of them are friends of mine.
Yeah.
And so we get together. It started off, we got together, there were 12 of us. That's how it started.
That's cool.
And in the whole world.
That's very cool.
And then gradually that's sort of grown now. Yeah. But we still have a meeting every year. I'm off to that. The first one for a few years will be in October this year.
Fantastic.
So everyone has ideas, and we all put them together and develop them together. And it's incredibly cooperative, so it's not sort of backstabbing stuff. And so we all develop things and get together and workshop things and come up with new ideas. Talk about things we've seen and ask other people for their ideas.
How did that start? Was it something that were you involved in the evolution of that?
I was.
That
Luckily I was. So a friend of mine, his name's Richard Villa, he's an Englishman, and he started the group. He just got 12 people together. He selected who he was going to ask, and dragged us all along to a meeting and said, okay, here's what's happening. We're starting this organisation. And he allocated everyone jobs. It was supposedly democratic, but it wasn't at all. he was in the SAS, and so that training came to the fore. Yeah. He said to the Swiss guy, "You're Swiss, you can be the treasurer." that
was stereotype, isn't it?
Yeah, there was total stereotyping, and that was in 2008 that started.
Is there a healthy level of discussion and or disagreement that happens in that group at a very healthy level?
Absolutely.
Do you think the reason I ask that is one of the things that we're trying to foster with these conversations, but also I don't think happens enough, is healthy discussion and disagreement where it doesn't turn into animosity and stupidity, basically. Yeah. A lot of it, unfortunately, seems to be happening online, which I'm sure you hopefully try and avoid.
I avoid totally.
Yeah, good.
But there's I used to look, but I don't bother.
Yeah, there's some ridiculous things that happen where they seem like they should be constructive conversations.
Yes. They end up in abuse.
Yes, yeah. What do you think actually will allow us to have those kind of conversations where it's constructive and you can disagree and say, no, I think this way would be better, or whatever it is, and actually get to some constructive growth in the profession, and all healthcare professions, really?
I think most of us try to do that, don't we?
Yeah, I think the silent majority do that.
Yes.
It's the loud people who like arguing with each other.
Well, I think it's
sometimes.
one of the issues we see with social media, because you end up saying a lot of things that you wouldn't say in a face-to-face conversation.
Sure, because you're anonymous.
Yeah,
Absolutely.
There's research on that actually.
Yeah,
Yes.
exactly. I think that's often one of the big missing things, where it's like one of the reasons why John and I enjoy doing this podcast is
Yes.
not to meet people like yourself, but the interaction that you get and the learning that we get is so much more positive when you actually have someone there to speak with you, as opposed to just via correspondence on an email or, let alone say social media.
Yes. Yeah. I find meetings are like that, and that's why I'm relieved that we're not just doing Zoom meetings the whole time.
Yeah, I think they got tiresome really quickly.
Yeah. I think they're better than nothing, but only just.
Yes.
And you lose so much, whereas face-to-face meetings, I found most of what I learned is not in the actual meeting, but talking to people outside it.
Yes.
And with Zoom, you have none of that.
No. Yeah. I think one of the things that we'd like to talk to you about, which we mentioned before, was around like the hip specifically. Now you're very well known for innovating a number of areas in terms of hip surgery. Particularly one of the areas is around FAI, or femoroacetabular impingement, like symptoms and pain. Can you give us a bit of a background on one, how you sort of started to think about that problem, and then what you've been doing for it initially, and now even what you're doing maybe now that may have changed over time?
Sure. I think it'd be really interesting to hear too of when is FAI a problem as opposed to when it isn't, because given that it's such a common morphological change within the hip, particularly in field-based sports.
Yes.
What are the things that you...
That's probably a really good place to start, because that defines it a lot, and it's where a lot of confusion has come into it,
Yes.
I think. So FAI, or femoroacetabular impingement, just refers to abnormal shape, or a particular shape or group of shapes that affect the hip. So, and to call it an abnormality is maybe stretching it a bit, because it's so common. So I think it's in a way a form of normal, but it's where either the ball part of the hip isn't round and part of it projects and causes catching, or the socket part of the hip projects around the edges or is too deep, and leads to the same problem. So it can lead to destruction within the joint, and particularly in very active people. But it is really common, and so depending on who you believe and which population you look at, just in the general population, it's more common in men, or particularly the femoral head part, the ball part, is more common in men. And that's maybe in 25% of men. So we don't call that femoroacetabular impingement, because they don't have symptoms, they don't have, as far as they're concerned, any problem. In fact, they don't have any problem. And it's only when it starts to cause damage that it is painful and progressively damaged then that's a problem, because that leads to arthritis, or potentially leads to arthritis in the hip.
So do you almost look at it as like a spectrum then, where like if you're getting bony structural changes, there is a reason for that. Maybe to some extent that's actually just, not maybe, most likely that's probably a normal process that we see, hence why you have a lot of people that are asymptomatic. But then there is a point where it does become a problem. So when do you start to see it as a problem, and I think more importantly, when does it become important to think about, say, surgical interventions as a primary treatment or management plan for it?
You said that in such a calm, rational way.
It's a very simple answer, isn't it?
Well, it's a very simple question. It seems a very complicated answer. To me, it's not very complicated.
Okay.
But I have a very simplistic way of looking at these things. So I think that, yes, it is a normal adaptation. So there's all sorts of evolutionary ways of looking at these things, which people have done and shown that it is an evolutionary adaptation. So that if you're an athletic ape who runs around on the ground, then the likelihood of you developing this shape of hip is quite high. And if you're someone who sits up in a tree as an ape, you won't. These things do not happen. So it's, in a sense, it's a way of strengthening the hip to cope with the stresses of running around.
Yes.
So it's a good thing. The trouble with evolution is it's only really aimed at getting you to procreate and then you can die. So what happens after that doesn't really matter. So this way of getting you to run around better is great, but once you start getting arthritis when you're 30 or 40, it's not so great at all.
Yes.
So there's just sort of complicated lead into it. But I think that if you have any shape of hip that's causing you no problem, well, it's causing you no problem and you don't do anything about it. So we don't do what's termed prophylactic surgery.
I was just going to ask you that.
That did occur at certain points though, didn't it?
In hip?
Yeah.
There's a few people do a bit of it.
Yes.
But most of them won't admit it.
Okay.
Because everyone comes down on them really hard.
Yes.
And says you can't do that. And the only time, well, sorry, I'm jumping a bit ahead. There are very few occasions where you might consider it, but they're very, very few and probably best ignored at the moment. So the straight answer is if you haven't got symptoms, don't touch it. So don't go doing x-rays of the whole population looking for how many people have this and offering treatment to people with no symptoms, because you'll be operating on an awful lot of people, most of whom never would have had a problem anyway, and you'll cause more problems than you avoid.
Yes.
So that's a really easy one. Then once you've got symptoms, in part it depends on the sort of level of activity of the person, what they want, how restricted they are, is it getting worse, and from testing how much damage has already been done inside the hip. So if you're an active person and you want to remain active, and the majority of people who come, that's the case, because it's active people who develop problems.
Yes.
So you can have this shape, a hip, and not do a lot, or sort of do activities that don't cause much trouble, like ride your bike or walk or swim. And there's a good chance you'll never have any problem with it.
Yes.
But if you do kicking sports, martial arts, so extreme movement type sports, and you're young, so you get pain in your hip when you're 20 or less, 16, 18 even in some footballers. And I say to all of them, I always say this, that you have options on how you treat this. You don't have to have an operation. There's other ways that you can treat it. And one is to restrict your activity. And they just look at me in horror.
Yeah.
And they say, you have an 18-year-old kid and he says, but I want to be a footballer. And I've worked really hard and I'm good. And you're telling me I have to stop. And I say, no, I'm not telling you that. I'm saying you could. But no one does. Because they're not the type of people who get the problem. If they were happy to stop, they wouldn't come and see me. They just stop.
So out of interest then, like if we look at, say, adolescents who develop these kind of problems, do you see that more within adolescents who specialise early on in a particular sport?
Yeah, and they train like crazy. So otherwise they don't get it.
Yeah.
They don't get pain.
Given that that's becoming more common, and I think the literature is supporting that as well, are you starting to talk to them about that, or do you feel like that's not necessarily something that you get into with them?
Talk to them about their training?
Yeah, and their parents about the process of, okay, you doing 6 football sessions a week, 6 days a week sort of thing is too much for a 14-year-old, developing athlete.
John and I were just talking about this before, in fact, of talking of the issues associated with specialisation, both from an injury standpoint, but also even from your ceiling for development as well. When you look at the likelihood of developing a professional career, you see much more generalisation in sporting endeavours through...
At least up until the age of 16. I know that there was a really good study done by the German Olympic Committee where these are all people that made the Olympic team, and of those that did more than one sport up to the age of 16, they were more likely to end up medaling compared to people who just made the team.
Yes.
So there is evidence to support even the performances, as Jack said, the performance ceiling. Is that something that you discuss with them, or is it not sort of something that you get into?
No, I do, or I try to, but I don't really have much influence, if any, on that.
No, well, neither do we. It seems like the popular idea at the moment is the more you do, the better you'll be. Yes. Particularly amongst parents who seem to be almost more competitive about it than the kids, which is another issue in itself.
It is. That's a big issue, that one. To illustrate that point a little, so one of my daughters was a very high level competitive snow skier. And when she was about, I think 13 or 14, I was unaware of it at the time, but her coach had her doing heavy weight deadlifts. as a 13, 14-year-old.
Yeah.
And now she's 34, and she's got quite severe spinal disc degeneration, causing major symptoms and severely affecting her life.
Yeah.
And it just seems to me that having very young kids and really pushing them very hard to exercise like crazy in very confined ways with heavy weights is not a really smart thing to do.
No, and I think there's lots of discussions about that, about what's appropriate level of
but that
stresses.
applies across a whole range of things.
What's appropriate level of stresses for different age populations and what that means for future. We spoke about this concept a lot, and it probably leads nicely into a question around joint degeneration, but is when you have someone who's undertaking these activities, once they get to a certain level, there is a divergence of health to performance that occurs with a certain level of training and sport.
Yes.
I don't know that these discussions are necessarily being had. Everyone associates exercise, these days at least, with health.
Yes.
But once you get
more
to
exercise is more health. Yeah.
Once you get to a certain level of performance, as I'm sure you deal with every single day, it actually starts to be damaging to your, and particularly your musculoskeletal health in the long term.
Yes.
Not always, but there is an association.
Certainly potentially, yes.
Yes. The question that I wanted to get to is, what are you seeing in terms of the activity that people do and what that is meaning for things like joint degeneration, and what are the current options that they have going forward for managing these kind of joint degeneration? If you've been, say, high level, someone in snow sports, or you've been high level in football or rugby or soccer or whatever it is, and now your hips, knees and ankles are starting to fall apart in your late 30s, early 40s. What are the things that we're starting to see now in terms of managing those, and where do you think the future goes with that?
Okay. There are some parts that are attempt to be made to manage it now, just in the way people train.
Yes.
And the training loads they have, and how if they have an injury, those loads are altered to compensate for that or to protect. So there's an element of that, and you certainly see that, and in football teams, for example. So in regard, and I keep coming back to hip, but it's what I sort of know a bit
that's what
about.
you work in, yes.
And so you see that now, so that kids in the draft are tested for their hips,
Yes.
to see where that, it varies in how carefully it's done, but it's done to some extent by all sorts of people.
What kind of testing do they do exactly?
They look at the range of internal rotation. That's a sort of starting point.
Yep.
Yes.
And then, because that's a real marker for this type of problem. And then if they have significant reduction, I don't know if they do it now, there was talk that they'd x-ray them or scan them, or to look to see what the shape of the hip was. I don't think they do it, but there was talk of it. So they may change the way they train on the basis of that, or at least if they start to develop symptoms of groin pain or osteitis pubis or something like that, then there's a whole variety of different symptoms they may get. And then you can alter how much load you put on them in training and how much twisting, turning, agility type training they do. So that's to try to manage that to a degree. And there's some sense in that. But there's a whole lot of things. For example, knee injuries, it's pretty hard to really, you can predict them because they're very predictable, or at least into averages they are. And there's training you can do to try to strengthen knees and protect against ACL injuries. So people try those sort of things. So you try and protect by having better muscle strength and coordination, or by avoiding heavy activities that are likely to precipitate problems. I'm sure there's better ways to go, but they're the sort of things that are done now.
They're the basic foundations. Yep.
Yeah. So there's an element of all of that.
In terms of, like, as I said, as someone does start to get degradation to the joint, and I think one of the things, having worked a little bit in elite sport, there is an element, particularly sim-fielded sports, of getting people back out onto the field.
Yes.
Intra-articular injections, things like that probably are not good for joints in the long term, but allow for participation in the short term at times.
Yes.
What do those kind of things tend to lead to for you in terms of what you see 10, 15, 20 years down the track?
I think it's a whole lot quicker than that.
Okay. Well,
but maybe that. But so I try really hard to stop people having certainly repetitive intra-articular injections. I think it's really potentially very dangerous because it covers up. It removes that feeling of knowing what you're doing to yourself and allows you to do way more damage without really knowing it. So I think that's potentially not a good idea at all. We use them. Sometimes we use intra-articular injections as a sort of diagnostic tool to see if it will give pain relief and localise the area where the pain's coming from, because that can be really helpful. Sometimes people may have some activity, like for example, they've got the grand final of their competition coming up, and they're desperate to play, understandably. You say, well, with the injection, there are these downsides to it. There's potential risk, but it may allow you to play that game at or near your best. Well, you just have to give them the opportunity. Most people grab that. They don't hear the bit about downside. They just want to play.
You say that though. Actually, I saw recently, I think was there an IOC conference this week? I think it was a sports medicine conference, and actually corticosteroid injections have actually been put onto the ban list.
Oh, they've done it again, have they? They come and go.
Well, in competition at least. So they actually, it was quite funny. It almost reminded me of the East Germans talking, but the actual person presenting was talking about clearance times and how quickly it comes out of your system, and it started to make me think about what some of the discussions about anabolic steroids. But
I've never regarded an intra-articular injection as performance enhancing.
No, but I think it's one of those things when those people start talking about clearance times, you start thinking to the good old days of East Germany.
Sure. Yeah. When do we have it, and when will they be able to pick it?
Yeah.
Yes. Yeah.
So, going on with talking about management. What are, sticking to say perhaps a similar population group when we're looking at, say, your, it doesn't have to be an elite athlete, it could be a sub-elite or even a recreational athlete, but looking at different treatment options, so, surgical versus, potential, injections versus, say, conservative management. Do you have particular principles that you follow to determine when you think someone's going to be a more appropriate candidate for surgery versus not an appropriate candidate?
Is this in someone who's developing joint degenerative changes?
Correct, yes.
Yeah, I do. They're not very well evidence-based yet, and we've been trying to do that and pick out characteristics that say that with hip problems that you're likely to do fine, say, with physiotherapy, or you're not, and you can try it, but if it doesn't work in a relatively short period of time, or at least some indication it's going to work, then you should think seriously about having surgery on your hip. Because, as you know, we've looked at both surgery and physiotherapy in the treatment of these hip problems.
Yes.
And several groups have done that, but we did here. So we had a group in Australia, and we got a grant from the NHMRC, the National Health and Medical Research Council. And they gave, I'm not sure if gave is the correct word because it took us 4 years of trying to get it, but we got this grant of just under $1 million to do it, so it's a very expensive thing to do. And so when people say, you need more research, or that's true, but to do it is hard, and to get the money is extremely hard. So we did, and we compared a group of people with these same hip problems who half of them had physiotherapy and half had surgery. And the follow-up's short, although it's ongoing, but at a year, both got better, but the surgical group got more better, if that doesn't make sense. Their improvement was greater. But it would be nice to be able to say, well, that's on average, and averages are fine, but they don't necessarily tell you about any individual.
Yes.
And so it would be really nice to be able to pick someone who's going to do really well with physio and avoid having surgery that's not necessary. And equally, it's been shown that if you have surgery and you delay it, then the outcomes are worse because there's more damage by the time it's done. So it'd be nice to avoid that situation as well. But when we've looked at the group we've got, there's about 100 people, 99. It's I'm not sure if it's just not big enough, or we've looked at the wrong things. But so far, we looked at things like age and sex and weight and all that kind of normal stuff, and we can't pick, or even on size of lesions at the start, that didn't differentiate who was going to do well and who wasn't. So we don't have those answers yet.
I was going to say, what about just with your own clinical experience? Have you identified observed any particular patterns?
some are pretty obvious. You know, like if you've got someone who's got really major lump of bone that's really catching a lot, that's severely restricting their range of movement because it just won't allow that movement to happen. They're young and they play a high level sport. I think that's a pretty easy one.
Yes.
And then at the other end of it, you've got someone who's got a relatively minor shape abnormality. Their symptoms are pretty intermittent and really only after they really flog themselves, and they're happy to cut back a bit. Well, that's pretty easy too. So you've got operations at one end, no operations at the other. But the trouble is the great majority of people are somewhere in the middle, and that's when it gets much more difficult.
Well, the other thing too, I think, is a bit vague and arbitrary. As you say, surgery versus physiotherapy, but what does actually physiotherapy mean?
Yeah,
because
sure.
I mean that's quite a broad thing to state, and it's to state in terms of like, are we using exercise interventions? Are we using manual therapy? Are we using a combination of both? What type of exercise interventions are we using? Do you have any expectations, or have you observed with some of the, say, physios that you work with, particular emphasis on certain conservative management protocols that have better outcomes than others? Because
it's so variable, it's hard.
Well, that's the problem. I think that's one of the things that we're trying to help with, is at some level at least, is trying to formalize how people even approach these kind of problems. As you said, you're trying to pick out the subgroups of who's going to maybe do well. We're trying to almost do a similar thing when it comes to profiling and subgrouping. What kind of activities are the ones that are important?
Yes.
Because one of the big gripes that we have with our own profession is that there's too much variability between someone doing something well and someone doing something poorly. And even unfortunately, you read some of the research and you think, well, if that's all they did, then they're going to fail. Of course they're going to fail. Right? Which is not necessarily a criticism of the people running the study, but it's just the reality.
We got it because it's hard to do this.
Yeah.
So when we were setting up our study, we had to say, well, what does surgery actually mean? What will the surgery entail?
Yes.
That's a bit more straightforward.
Yeah.
Or a bit.
You hope, yeah.
But there's still some variation
Yes,
there,
of course.
quite a bit, not to mention in the skill of the person doing it and who you're allowed to be involved in the study.
That's one of the biggest challenges, isn't it? Because it's the elephant in the room. People don't want to talk about the fact that within surgeons, there's big variability in terms of skills, right? Same with, we talk about all the time on this discussion, in this podcast, that there are good physios and there are terrible physios. Sure. And I'm sure it happens in surgery as
Absolutely,
well.
of course it does.
But people don't want to talk about that because, especially in research, because that really probably heavily changes the outcomes that you might see in a surgical intervention if you handpick the surgeons that are doing certain things in a particular way and you're confident that they're going to apply those consistently.
We did our research here using the same protocols as a group in England.
Yes.
So what was actually done, at least as much as you can tell from a protocol, was the same.
Yes.
What was different was here we selected the surgeons who were involved. Well, when I say we,
you
I.
did. That's
largely.
That's great.
Well, I was given a kind of veto. And so, because what we wanted to do was see what ideal best case surgery, as far as we can tell it is,
of course, yeah,
would look like. Because there's no point in just having a whole lot of people botch up an operation.
And then going, it didn't work.
So it didn't work, exactly. Whereas in England, they just had everyone who did the surgery who wanted to be involved was.
Yes.
So it's far more people. They were scattered all over the country. Some only did a couple of operations in a year, and others did a whole lot. And our outcomes were significantly better.
And that's the funny thing is,
I'm not saying that doesn't prove that that's why.
No,
but they were.
You actually hope that that's the case.
Absolutely.
Right, because as you said, when we spoke about training and things before, you hope that people are getting better by actually, one, being exposed to good good teaching, good learning environments, opportunities to grow through, whatever they're exposed to, but you've actually created the opportunity for better surgeons to be operating.
We tried to do something similar with a physio.
Yeah.
But that's much more difficult. Because, firstly,
I'm not surprised.
Your question, what is physio, or what do we mean by do physio? So we had a group of physios who worked in centres where they did lots of hip problems, hip surgery, not necessarily, but hip surgery part of it. So these are the main physios all around the world. And we said to them, can you please list for us what you feel are the really important things, and then we got them all together and we got them to nut it out on, come up as best you can, because we've got to have a program. Because if you're going to compare something, you have to have something fairly rigid you're comparing to.
Yeah.
And not just say, oh, everyone do their own thing. So we did that. And at the time, it was considered best practice physiotherapy by world experts. So that was the best we could do. And then they were all trained, every physio who was involved in it did a special training course to make sure they were all doing the same thing. And patients filled out a diary of exactly what they'd done, so we could make sure that they were doing what we thought they were doing. So that's about as good as we can get. But the trouble is that it takes you a couple of years to get the protocols all set, and then a couple of years to recruit, and another year to actually get any sort of outcome at all. So you're talking at least 5 years from when you start to when you get some sort of 1 year outcome. And of course by then there's a whole lot of physios come along and say, oh, that's really old fashioned, we're much better now. And that may be true or it may not, because there's no research to back that statement. But they certainly believe it to be true.
Yeah, and the other simple standpoint to consider from like a conservative management is how relevant is that exercise or group of exercises to the individual. And I think that's probably one of the issues or gripes I have a lot with research within our profession is you use these protocols, which actually may be appropriate, but that, you know, the simple thing of doing testing to identify, do you have particular weaknesses? If so, what particular planes? Do you have deficits in your flexibility? If so, in what particular planes? And you actually start to tailor a program based on that individual's ability or inability. And more importantly, how do you progress that over time? Because how are we going to make sure that we maximize the adaptations that we want within that individual to see improvements in their overall hip capacity?
This is exactly, you know, we had this discussion last week with Paul Coburn, who's talking about, I'm sure you would have seen the GLAD program.
Yes.
And he was saying that the people that do well in that typically are people who have very low level of activity and have these sort of arthritic changes. People who are very active and maybe have a background of being, you know, very active and they've got some level of strength and all those kind of things don't tend to do as well because the program's actually pitched too low for them.
Yes.
So it's not an actual, the stimulus that they're getting is not of high enough magnitude to actually create change.
Not much different to what they do already.
And even
it's probably lower sometimes.
And even if it is appropriate to begin with, how does that change over time? Because you know, like any type of strength and conditioning or just rehab process is you're going to see dynamic changes where the stimulus you need to apply to create the adaptation that you want is going to continually change over time.
Yes.
But it's one of the difficult things, and you know, it's I realise it's difficult from a research perspective because you want to have it to be very structured and replicable over like different clinics and so on, but that issue of how you follow a protocol versus maybe these are the parameters that we use to go, we want you to identify or assess these particular strength capacities, these particular flexibility capacities, and then based on deficits, these are the kind of things that we want you to apply to see changes over time. And that's one of the things I'd be interested to see be applied from a research perspective, but I don't think there's very much done in that area.
I don't think there has been, but I think it's a really important thing to do. And I think there's way more physios now who are really interested to do that kind of thing. Yeah. And I think that's great. Yeah. Because then we'll be able to compare things way better. And so we're comparing it to physio that actually works. And we know it works because they've tested it against all sorts of other things, and this is the best one right now. Correct. And it gives you a standard then to measure some new thing and say, the guy who comes along and says, I can do it much better. It's like, fine, prove it, because you can compare it.
Well, it's actually similar to what you said before of like, you get an idea of the average effect, but within that group, you're going to see some people who have really positive responses and some who do not at all.
Or get worse, yes.
Exactly. And there's obviously going to be reasons for that, and we probably can start to actually nut that out when we identify other components, whether it's related to the individual's physical capacity or their training history or whatever it may be.
Sure. Oh, and I think that'll help us all. So whether you end up having operations or not doesn't really in that situation. You'll find that better physio will help both. And it always amuses me a bit that sort of this, what to me is a very false dichotomy of saying you'll either be treated with physio or surgery. Because that's never true. Sure, you can just have physio and have no surgery, but it's pretty rare that you have surgery but no physio. Because physio is part of it. The rehab is a major part of any operation, and it's a critical part. Now people talk about prehab, which is a word that I don't really like much, but the idea of some conditioning prior to surgery and greatly improving the outcome and the speed of recovery is absolutely recognised and strongly encouraged. So I think to say, oh, you'll have physio or surgery is ridiculous. You might just have physio, but you will not have surgery without physio. It's a really important part of it.
Do you see that as a general issue within people that you treat, with the expectations of what the outcomes are post-surgery and the timeline for recovery?
I know that Jack sent this through this question, but it's something that we asked Pam, who has just finished her orthopaedic training, but this expectation that the surgeon, you know, the buck stops with them and they're going to solve the problem for that individual. How do you, like, you're obviously a very experienced surgeon, how do you deal with that, and how do you manage those expectations of that individual so that they're not expecting some sort of magical outcome when you're looking at their presentation saying, okay, this is what I think will be a likely ballpark for you?
It's a hard one, isn't it? Because I think you want to give people realistic expectations.
Yes.
I think that's really important. But you don't want to hold them back too far, because then you'll put a lid on what they think they can achieve, and that will become self-fulfilling.
Yes.
So you want to be able to give them optimistic projections, but not stupid, unrealistic ones. So I try really hard to do that. And I had a lady who said to me, who arrived, first time I met her, she said, "Thank God I'm here, you're my last hope."
No pressure.
I said to her, "That's a very heavy load on my shoulders." I said, "Can you tell me who you've seen already?" She said, "I can." I said, "I've been to the chiropractor, I've been to the naturopath, I've had orthotics." She listed a whole lot of people who then got progressively slightly more off-centre as she went. And I said to her, "Well, for the problem you've got, have you ever thought of seeing someone who might be able to help you?" Because I felt the people she'd seen, she picked poorly. So
how did she take that?
Oh, she probably thought I was some arrogant idiot. I don't know what she thought, but but I think expectations are critical.
Absolutely.
But I won't accept anyone saying to me, you're my last hope. I just say that's not realistic, and you don't look at it that way at all. And I try really hard to map out what I feel is possible to achieve, and that understanding you may not get to that, but there's a high probability you will. But it's not just a matter of me doing an operation and suddenly all these things are going to happen. There's way more to it than that, and that a large part of it is them, not me, and help from various other people. And so it's a real team effort, and what I do is very much a team effort. I work really closely with a physiotherapist, Amir Takla, who actually works in the room next to me.
I know him. He actually taught. Jack and I both at Melbourne Uni, and he was one of our teachers there.
I operated on him. That's how I met him.
Oh, really?
Yeah. So he came to me a lot of years ago now, and I operated on his hip because he'd hurt it, I think, in about 2000. He was at the Sydney Olympics. He saw a whole lot of the sports guys up there, so the cream of sports medicine people in the country. I think he got 6 different diagnoses, none of which were his hip. And so he did all his treatment, things that they told him, and ended up I operated on his hip and he got better. But then he found that the physio that he'd been taught way back, which was really for hip replacement more than anything else, and he tried doing it to himself and he just got sore. So he came up with a whole different method, which largely has led to the sort of things that we do now. Yeah. So fairly extraordinary.
Yeah, that's good. I think one of the things, I don't know if it was in the questions that we sent through, but I wanted to ask you was, what's exciting you in the world of hip surgery at the moment?
What is hope? Hope. The trouble is we've all been hoping for things for so long. So things like cartilage treatment, stem cell treatment, that kind of stuff. And all the buzzwords like gene therapy. All that
where are we at with that? Because we've had a number of discussions. And
what we're going to say, are there technological solutions do you see to these type of problems, specifically with joint related or degeneration or osteoarthritis?
Well, we all like to think so. So I think there's 2 parts to it. I think there are sort of underlying mechanical problems that simple people like me can deal with, and then that won't bring back worn out cartilage. We have at this stage we have no reliable way to do that at all. But that would transform everything if we could do that.
Do you think it's just hope? Because you hear of people doing some of these things, stem cell, gene therapy stuff, that doesn't seem to be supported if you go looking through the literature.
Correct.
but they're offering it anyway, which
Yes.
I don't know how appropriate that is. And like Jack and I often have had a couple of people who are looking for solutions because they're at that point. They're saying, "Oh, what about this? What about that?" And they get so disappointed when you say, "No, it doesn't seem like the technology's there at the moment." And they say, "Oh, well, this doctor in such and such said that they can give me this, but it's it's really expensive," and this and you sort of say to them, "Don't waste your money on it."
Yes.
What are the conversations that you're having with people around stuff like that? Because it's
Similar.
Yeah.
I find it a bit hard because sometimes, like there's one of the doctors who does a lot of stem cell stuff who asks me to see some of the patients because he says they have very specific mechanical problems in their hip that he thinks that I can help with. And he will do stem cell injections. And I don't want to say to people, "You've just wasted your money." And anyway, that's only my opinion.
There's still more research to happen, and
Sure,
there's more
and
technology.
it's developing, and,
yes.
it's getting a bit better, but a bit.
Yeah.
But they've already started this whole process, and they've paid out the money, and they've had their stem cell, well, whatever they are, is growing, and they're going to have their injections. So I want them to go into it at least with hope that it's going to be helpful to a degree, but it's generally not, or it's limited. It's
Yes,
limited.
at
So
the moment,
it's unfair
yeah.
to say it's not. It's limited, and to me, the great majority of people are not going to get much benefit from it for a lot of money.
Yeah.
It seems the issue too is looking at osteoarthritis. It's quite a complex entity that doesn't have a simple solution. Like as opposed to sometimes like bacterial infection where
Sure.
perhaps antibiotics actually provides a really clear.
Or a broken bone.
Yeah.
Or a broken
Yes,
bone,
yeah,
exactly.
which is pretty straightforward.
Yeah.
And it's interesting because this really ties into thinking about that evolutionary mismatch between our current environment and lifestyle and the maladaptations that occur with that. When we think
Sure.
about the lack of physical activity, when we think about even like some of the other systemic issues like the strong correlation with, say, metabolic syndrome for increasing the likelihood for developing things like OA. And it's interesting to note that, we were talking about this before, John and I, that they've tried to create, say, drugs to mimic some of the cellular changes from exercise in a drug, but they've all failed so far because of
Thankfully.
reality is, when the reality is when you apply a mechanical stimulus, you're creating multiple responses and adaptations to multiple different systems.
Yes.
And I think it's one of the issues that we see at the moment is people are hoping or looking for a technological solution to quite a complex problem. But I was interested to hear, like, are you involved or have you heard from any of your colleagues or researchers about how we implement changes more at a global societal level to be able to address the fact that we're dealing with more and more chronic conditions that are associated with poor lifestyle factors?
So the obvious one is that with lower limb arthritis anyway, be that, well, particularly knees, maybe ankles, hips to a degree, is overweight. And everyone's well aware of that. There's nothing new about that.
Yes.
But to actually do anything about it, it seems to be incredibly difficult. And I've certainly had that experience. I still try. I tell people who are very, very overweight with arthritic hips that it's really important that they lose weight, that it may or may not help their hip pain. Well, it doesn't tend to help hip pain that much. Knee pain a lot, but hip pain not so much. But if they end up having surgery, it certainly makes a significant difference to their outcome and their risk. So overweight people are more likely to get infections. It's just more difficult surgery because it's just hard.
Do you see slower recovery times?
Yeah, sure, all that. They still get significant improvements. In fact, their level of improvement sometimes is greater because they're coming from way lower down to start with.
Sure.
So it's hard to say to people, oh, you can't have this operation like they do in the UK. They have a BMI limit. And if you're above that, you can't have it until you've lost weight. And you can see why they do that. From sort of a health economics perspective, it makes some sense. But it's pretty tough on people.
Yeah, absolutely.
Yeah. But they all say that they're all going to lose weight after, and very few do. And a few do before, and some are really good at it, but most aren't. And so if you're going to sort of hold this up as the answer, well, I don't think it's going to work very well, at least unless you come up with a much better way to get people to achieve it.
Well, Yeah, that's the $1 million
It's
question,
hard,
isn't it?
It's really hard. Excuse me. Because we all know it's the right answer. It's just getting there.
Is there anything else that you think is on the horizon that you're actually quite interested in and you're sort of watching to see whether it does have any benefit? Like, to give you an example, one of the things that Jack and I have been seeing a lot, and it seems to have happened a fair bit in tendon, and we're not sure whether it's going to be useful in something like, articular cartilage, but is in tendon, it's becoming really popular for people to supplement with things like type 1 collagen and then apply a mechanical stimulus.
Yes.
Obviously, articular cartilage is made up of type 2 collagen, which is a little bit harder to get, but there's been some really low-level starting discussions around, okay, if we actually really increase the amount of intake of type 2 collagen and apply an appropriate level of stimulus, whatever that is there any opportunity for changes within that articular cartilage? Now, at the moment, it's so early, it's almost impossible to tell. But are there things like that you're sort of keeping a long-term view on? No, not necessarily related to nutrition, but
not
other
really,
things.
Beyond interest. And just sort of...
but even of your general interest,
I try to read reasonably widely and about things that aren't directly appropriate to what I do, just because I'm curious. And obviously it'd be nice if there's some better answer comes along that says no one will need to have their hip replaced one day. You'll find ways to maintain your own, then that'd be fabulous. But I think that's a long way away.
Yes, at this moment at least. In terms of like surgical things, is there technology from your end? We spoke to, as we spoke with Pam Bokel about this, about the idea of like, changes in robotic technology, the guidance systems that you use, all of these kind of things. Are these things that you're seeing coming and that you think actually this is going to make surgery, better, more accurate, more interesting, give us better outcomes?
It's certainly coming. They're here. So there's lots of it. There's an awful lot of marketing hype about it.
Yes, that seems to be the case.
There's an awful lot.
Especially from the companies that produce them.
And the surgeons who use them as well, although they're not allowed to officially, but so companies do it on their behalf. So there's a lot of that. The actual outcomes that have been demonstrated, the differences are not great.
Yes, okay.
And there's good and bad, differences both ways, good and bad. It seems to make sense that you do something accurately. It's got to be better than doing it poorly.
Yes.
But there's a range of what's okay. So it's not as if there's 1 degree is perfect and everything else is shocking. And there's a lot of it where no one knows quite what that degree is. So there's a range of opinions on what you should be aiming for. Which makes it a bit hard because you can very accurately achieve something, but if you don't know what that something is you're trying to achieve, then it doesn't matter how accurate you are. So there's an element of that too. So there's a whole lot of these things coming to it. But there's lots and lots of things that are called robots, which are really more sort of guidance systems.
Assistive technology.
But there's lots of that. And it's certainly popular.
Are you involved in the development of that? I would think that someone with your level of experience, and even the story you told earlier about you and your mate doing some engineering of utensils, that you would kind of be a candidate to actually bring into those conversations.
I was involved in it early on with computer guidance for knee replacements, so I was involved in that very early on, but I don't do knee replacements anymore, so obviously I don't do that. There are some similar things with hips, but I haven't really been much involved in that. I'm getting to the end of doing hip replacements now, so it's too late for me, but there'll be other people who do that.
Good. Is there anything else that you wanted to ask?
No, I feel like I've covered most of the areas and just talk to you about, John.
Was there anything that you wanted to bring up that you thought might be important for...
No, I found it a really fun, interesting discussion. I think you've covered a lot of areas nicely. I'm just really pleased that there's more and more cooperation that's appearing. And when we were talking earlier about the social media and people piling onto each other and stuff, there's so much of that goes on, and so much just prejudice really based on not very much, or protecting one's own interest or whatever. So it's really nice to have a bit of a wide-ranging discussion and try and explore the different elements that lots of people can bring to hopefully get better outcomes.
Yeah, look, I think you raise a good point where the reality is a lot of people who have these arguments and discussions, there's always elements of truth to what they're saying. And interestingly, it's something that we often talk about with this idea of complexity is you've got a complex situation when you have evidence to support contradicting hypotheses.
Oh, sure, yes.
And you can always find that in the literature of the fact that there is such variability in outcomes or results, and the reality is there's a lot more to be understood with regards to how we actually implement this all into clinical practice.
I think a little bit too, there's this idea somehow that randomised controlled trials somehow are the answer to everything.
Yeah.
And I find that, well, not true would be a starting point.
Well, actually, it's interesting you say that, because
Yeah.
someone as senior as yourself, like, can you tell us about that and maybe where you sit on that?
Well, obviously they're important, so I'm not saying that they're not important.
No.
They're seriously important.
We appreciate that.
But you have to understand there are some limitations to them as well.
Absolutely.
So in order for a trial really to demonstrate a difference, you have to limit the number of variables really hard. So, and the more variables you've got, the harder it is to show a difference, because you're not sure which variable it was that actually changed it. So ideally you come down to one variable, two different possibilities, and you compare those two. But that's pretty difficult. So when we're, say, talking about comparing surgery to physio, well, surgery is not all done exactly the same, and the physio most certainly is not all done exactly the same. So how do you come up with an answer that is, and it's only for the situation that you've created anyway. But
it's controlled. And that's
so you
the
take
point of it is.
This group of people, they're all between 18 and 22, and they all play football, and they're all right foot kicks and whatever. And then you say, I'm exaggerating, but, and then you say, okay, well, there's this difference, and then somehow that then gets turned into, knee arthroscopy doesn't work.
Yeah.
Which is silly.
We had this discussion actually, as we said, with Paul Coburn, and we spoke about the issue of a lot of healthcare practitioners, particularly in the education side of things. Most of the universities have adopted the basic concepts and framework of Sackett's model of evidence-based medicine or evidence-based practice. But they seem to have forgotten what the actual pillars of that of that model is. And it's, it was broken into thirds. First part was, clinical experience. The second was patient expectations and values. And the third part was, literature. It seems to now it's divided, and that was equally divided. Now it's 90% literature and maybe...
Nothing else matters.
Yeah, nothing else matters. And we're much younger than yourself, obviously, and a lot much less experienced, but we don't understand why that's happened, because we're getting really frustrated by this concept that unless you have literature to support it, and as you're saying, there's limitations with that, because unless it's the specific population that did exactly what you controlled, maybe it's not applicable to that individual in front of you. People will shoot you down and say, well, there's no evidence for what you're doing. And you say, well...
And somehow the fact there's no evidence equates to it doesn't work.
Yes.
It's just no one's actually looked.
What is it? Absence of evidence doesn't mean...
evidence of absence.
Evidence of absence.
Or the other way
around.
Yeah.
But you're talking about limitations with, say, an RCT, because I think we need to remember that in the real world, we're actually interested in outcomes.
Yes.
And we're interested in applying whatever interventions, even if they are multiple, to make sure that we optimise the outcome for the individual.
Well, another part of that I've been really interested in lately and sort of trying to follow, when you talk about sort of looking beyond your own field, is placebos.
Yes.
So one of my kids gets me to listen to this sort of spiritual podcast that is not really kind of my thing. But I really enjoy it because it's so different to my normal way of thinking.
Absolutely.
That it's fun. And they did one on placebos. And so I've looked all beyond that, and there's a place at Harvard where they actually study placebos and all sorts of stuff, which is interesting and fun. But here you hear people say also, oh, it's just a placebo. Like somehow that's a bad thing.
Yeah.
But people feel better. So why is that bad?
Well,
I think it should be maximised to add to whatever else we're doing to get the best possible outcome.
Absolutely, and what it also highlights is the interaction between your mind and belief systems and potentially your physiology as well.
Of course.
There's actually a couple of very interesting books that I'd recommend. There's one called You Are the Placebo by Joe Dispenza, and another one called The Biology of Belief by Bruce Lipton. And they really go into exploring how our mindset and belief systems influence our physiology. But, just to give an example, like John mentioning before about looking at tendon adaptations, and this is some of Keith Barr's work, who's over in the States, sort of looking at utilising not just mechanical loading to induce adaptations, but seeing how the tendon changes in response to loading with the addition to nutrient supplementation, specifically type 1 collagen. And it's interesting to note because I've talked about this before on this podcast, but a lot of tendon researchers will say that once you get degeneration within the tendon, you won't see any change to it, even in response to loading. And there's obviously research supporting that, but there's some of Keith Barr's research, and even if it's like we're talking probably case studies here at this point, so there still needs to be a lot more done, has shown that you actually can get remodeling of degenerative tissue with the application of not just mechanical loading, but that in conjunction with with supplementation. And so this starts moving into this whole new area of research of looking at the interaction of multiple interventions done in parallel.
Yes.
And this is where I think we probably see a lot clinically all the time, because we're probably tinkering around with using...
it's exactly like you said before. There's a such thing as and it's this or this. It's usually and.
Correct.
You'll do surgery and you'll do something else. It's not.
And nutrition's an increasing part of that too.
Massively. Yeah.
So there's all these things, and it's all very well saying, "Oh, we looked at that and it didn't work," but maybe if you just added a bit of something else, it might have worked better. And so to close your mind to it totally is foolish.
Yes, yeah.
Yeah, great.
Actually, that was just to finish on a different area.
Yeah,
that's good. Yeah.
This episode of Lateral Think is brought to you with the support of Strength by Numbers. Strength by Numbers have created an integrated clinical and sports performance system. The AXIT system uses force plates, dynamometry and strain gauges to objectively measure everything from isolated movements to sports performance tasks. The system has greatly enhanced our clinical practice, decision making and objectivity. We are no longer guessing. The greatest thing is its ease of use for both practitioners and clients. There are no wires, no fixed setup, and it is fully integrated Bluetooth system. If this sounds like something that would enhance your practice, visit strengthbynumbers.com and tell them that Melbourne Athletic Development sent you. John, thank you very much for your time. We really appreciate it.
My pleasure. It's been fun. It's been really fun.
Thank you so much.
Tell me about Strength by Numbers. So that's
we will after this podcast, mate.
Oh, it's finished?